Good evening. Thank you for joining us to discuss pharmacy practice change this evening. We have seen significant progress in practice change over recent years, both due to the pandemic, but also due to outstanding advocacy work. As you know, provider status was signed into law through Senate Bill 265 in January 2019. And since that time, Ohio has been working fervently on implementation. I am so proud of our faculty, staff, and students, many of whom are on the task force for provider status implementation, but all of whom are working to make a difference in their profession. I have told our incoming pharmacy students over the past 3 years that there has never been a more exciting time to begin a pharmacy career, and I truly mean that. The innovation we are seeing, and much of what we will talk about tonight, is incredibly impressive. Just today, I went to my local pharmacy, and a 2012 graduate of OSU gave me my flu shot, correctly selected for my age and risk, as well as a shingles vaccine. This was unthinkable just a few years ago. Tonight, we have the opportunity to hear from leaders at the local and national levels. I am thankful to each of these panelists for their time and thankful to those who are here as participants. This evening's moderator is Dr. Jennifer Rodis, Associate Dean for Outreach and Engagement, Director of Partner for Promotion Program, and Professor of Clinical Pharmacy. Dr. Rodis received her PharmD from Ohio Northern University and completed her residency at the Ohio State University. Welcome, Dr. Rodis.
Thank you, Dean Mann. During this time of uncertainty in our society and our world, time is seeming to me to be crawling along, while somehow it's also speeding right by. I feel like many of us are experiencing the world as both the tortoise and the hare, like in that old fable, and I find myself feeling this way regarding practice change as well. Here in Ohio and across the country, we've experienced rapid and unexpected shifts in pharmacy practice due to the pandemic. New policies have been introduced quickly through executive orders, such as in immunizations and telehealth, while other policies have continued to move along more slowly, such as federal recognition for pharmacists as providers of care. This evening, we have the distinct honor to hear from leaders who are intimately involved in the slow and steady, as well as the rapid change in pharmacy practice. I'm so excited to talk with these panelists tonight, so let me introduce them to you. Robert Weber is Administrator and Chief Pharmacy Officer at the Wexner Medical Center, Assistant Dean and Professor at the OSU College of Pharmacy. Dr. Weber is a 3-time alumnus from The Ohio State University, receiving his PharmD in 2010, his MS in Health Systems Pharmacy Administration in 1982, and his Bachelor's of Pharmacy degree in 1980. Ann Burns is the Vice President of Professional Affairs at the American Pharmacists Association in Washington, D.C. Ann received her BS in Pharmacy degree also in 1980. Ann serves our profession broadly and our college more locally as she sits on the College of Pharmacy's Dean's Corporate Council. Stu Beatty is the Director of Strategy and Practice Transformation at the Ohio Pharmacists Association and Associate Professor of Clinical Pharmacy at the Ohio State College of Pharmacy. Stu received his PharmD from Ohio Northern University and completed his residency at the Ohio State University in 2004. Welcome, panelists. So at this time, let's get started. I will ask a few questions and then we will open it up to the audience. If you have questions, please put them in the Q&A. And after we've gone through a few pre-prepared questions, we will take questions from the audience. So go ahead and start populating those as we move forward. I'd like to start with provider status. This has been an important topic for pharmacy. So I'd like to hear what's happening at the state and federal level with regard to recognition of pharmacists, as well as compensation for pharmacists as providers of care. Stu Beatty, could you start us off with this discussion on provider status?
Sure thing. I think I'm off mute. So before I get started, I just want to thank Dean Mann for hosting this, and Dean Rodis as well for allowing me to be here. Anytime I get to share ideas and be on a panel with Bob Weber, it's fun. And anytime I'm in the presence of Ann Burns, whether in person or virtual, it's always a delight. So thank you for even having us. As far as provider status, there's so much happening in Ohio, it's going to be hard to keep this short, but I'll do my best. Since provider status passed, as you mentioned, in January of 2019, and was began to go into effect in March of 2019, there's been a lot that's happened, and there's been a lot that's happened quickly in Ohio compared to a lot of other states that have gone down a similar path. One of the things that has led to that is actually, for folks that aren't aware, and you mentioned it in the title, Dean Mann went into an agreement with the Ohio Pharmacists Association and actually freed up some of my time, which has been really great for me personally and professionally, but I think it's been really important for the state as well, because there's been some dedicated resources to really drive home implementation for provider status. So what we have currently, as far as provider status goes, is we currently have 4 of the Medicaid MCOs in the state of Ohio are all involved in, we really try not to call them pilots. We like to call them phase 1 implementation, because that's really what they are. So they're involved in various stages of phase 1 implementation, and it's very geographic around the entire state. So we have independent pharmacies in Northeast Ohio, in the Dayton area. We're going to get ready to start some in the rural area where they're getting paid for services. We have FQHCs, and we have health systems that are all involved in various implementation projects with those 4 different MCOs. There's a little bit of variety in what those different plans are doing and how they're paying pharmacists, but the one thing that is consistent is they are all using E&M codes, and they're all using physician code billing, which I think is really, really important. And one of the things I've really tried to hit home in any of the conversations I've been having with the plans, that we don't want to look different as pharmacists. We want to be part of the team. And as part of the team, we want to be treated as part of the team, and we want to be able to bill and be reimbursed and have the same incentives as everybody else. So we're kind of starting this in a fee for service, I guess, model, where there's direct payment for those particular codes. But all of the plans and everybody I talk to recognizes and realizes that this is a time to come in and fee for service, but it needs to shift towards value-based payment relatively quickly. We don't know exactly what that's going to look like yet. And that's partially because nobody knows what that's going to look like for the rest of healthcare yet either. So we're going to try to kind of fit into that model. Now, most of our work has been in the Medicaid space. And if we want to circle back, or at some point, I can kind of give an update on where we are in the process of finalizing those rules, but I'll let others talk. One thing that has been clear to me since I started doing this in Ohio is that really the entire country really is watching this. We kind of have a joke that our motto, it used to be tip of the spear, that we were kind of doing things in Ohio, and we shifted that to the tip of the missile, because we think we're trying to blow this whole thing up in a good way. So really, I'll let Ann kind of talk about what's happening on the national stage and how what we're doing in Ohio is kind of translating to what's going on through APHA and other national organizations.
Sure. Thanks, Stu, and echo your comments. Thanks to Dean Mann and Dr. Rodis for the opportunity to be here tonight, and just am always in awe of the great work that's going on in Ohio. So we're all living vicariously through the efforts of Stu and colleagues in the current provider status initiative. And then Bob Weber is my longtime colleague. We graduated in the same class, and OSU Medical Center has really been at the forefront of a lot of positive changes like pharmacist privileging and so forth. So I'm really excited to be here tonight. Stu is right. From the provider status perspective, we are watching Ohio very, very closely and trying to learn a lot from the successes as pharmacist services move forward. I think from a framing perspective, I'd like to start out by just kind of putting context around provider status, because I think if we ask 10 different pharmacists what provider status means to them, we'd probably get 3 or 4 different answers. So from a provider status perspective, we really look at it from 3 different angles. The first is the pharmacist recognized in statute or regulations as a provider? So is there a clause that says pharmacists are healthcare providers somewhere in state law or regulations, or at the federal level? The holy grail that we've all been working for what seems like forever is provider status in Medicare Part B, like in Boy, which, as I would very much echo Stu's comments, we want to be where all the other providers are. That's where the incentives are in the healthcare system to pay for providers to avoid costly hospitalizations and ER visits and so forth. So the first is there a statement somewhere that says pharmacists are providers? The second is scope of practice. Do pharmacists have a scope of practice? And as everybody knows, scope of practice is at the state level. So do they have a scope of practice that allows them to practice at the top of their training? Well, oftentimes you'll hear top of your license, but if your scope is pretty restricted, then maybe your license isn't the best place to be aiming for. So scope of practice, which I know Ohio has made great inroads in the last few years to expand pharmacist scope of practice so that pharmacists can prescribe, modify therapy, order lab tests, and some of the key facets of what we look at for optimal practice. And then the third, and honestly, in my opinion, it's the most important, is payment. And if we don't have payment, we're not going to have a sustainable model moving forward. And I know everybody knows that. But really looking at where are pharmacists being recognized for payment. And so I'll try to keep this short too, because I'm like Stu, I could probably talk the whole hour. But from a payment perspective at the federal level, pharmacists are still not recognized in Medicare for as providers. Their services are not recognized for payment. So the primary mechanisms of payment through Medicare right now are either in what we call incident to physician billing, where the physician or another prescriber bills for the pharmacist services. And when we get to telehealth, I'll talk about some exciting inroads in that area. But incident to billing also comes with its challenges, and we have some pretty significant challenges coming in 2021. So I think it's important for everyone to be aware of it because we're going to have to advocate extensively. The other mechanism is Medicare Part D, the prescription drug benefit, where pharmacists are one step removed from CMS. So we're not really recognized as providers in Medicare Part D. There's a clause in the law that says that we may be paid as providers, but we're paid by health plans, not the federal government directly. And I think one of the other big aspects of this is that a lot of private sector payers in particular follow Medicare. And so it creates a significant barrier for us if pharmacists are not recognized. That being said, during this pandemic, there has been a lot of effort by CMS to recognize pharmacists from a scope of practice perspective around ordering, which is something that pharmacists generally are not recognized for by CMS. So ordering tests, ordering vaccines, that is an important aspect, and they've tried to clarify some workarounds for payment, but I'm not sure it's something to celebrate. So we often say that we feel like value-based arrangements and states, and maybe the private sector to some degree, are going to end up driving provider status. I think we're starting to see more and more states. There are currently 8 states like Ohio that have what we call an anti-discrimination clause. So if pharmacists' scope of practice, and if pharmacists have a scope of practice and they're licensed and they can provide certain services that health plans or Medicaid pay for, then it would be discriminatory according to their insurance code for pharmacists not to be paid. So we have 8 states so far, and we also have 17 states that are paying pharmacists for some type of services in their Medicaid program. So, you know, at some point we're going to reach a tipping point. We're going to have a critical mass. We need more expansion of the types of services that are being paid. But truthfully, I have not seen more momentum in the many, many years that I've been working on this than I have in the last 2 to 3 years. So I agree with Dean Mann. It is an exciting time to be a pharmacist, and we just have to capitalize on the opportunity. And Bob, I'm sure you have thoughts from the health system perspective.
Sure, absolutely. Welcome, everyone. So thanks for having me. I do want to, though, reach out and sincerely thank all of the pharmacists on this call who have spent the last 8 months, 6 months in very dangerous situations, taking care of patients who need us. So you guys are the heroes. And I'm a director of pharmacy, and I see some patients, and I'm around COVID patients, and I come here every day. But you actually work with them, teach them about their medicines, help them get medicines when they've lost their jobs and they can't afford it. And so thanks to you for everything that you do. Yes, the health system is very involved with scope of practice issues here at Ohio State. Our pharmacists are credentialed by our medical staff. They are considered mid-level providers. In fact, I was in a meeting just yesterday where they approved some privileges, and we have all told around 25 to 30 distinct privileges. Our pharmacy residents also have privileges, which is very, very unique. And the pharmacists manage many therapies from soup to nuts. COVID therapies, for example, hepatitis C therapies, diabetes. I know Dr. Beatty is, obviously credentialed as well within our organization, and he provides independent practice to our diabetes patients. So the scope of practice at Ohio State and across the country is continuing to grow. And what we really need, honestly, what we really need is research to show that pharmacists make a difference. I know that they make a difference. I hear it every day from our physicians that we make a very big difference, but we need research. So as we develop and design these studies, I think we'll get more traction. And as folks like Dr. Beatty and Ann, advocate for us, we will get there. We will get there, but we need to continue to push the envelope to develop those relationships with physicians and to just move forward and take care of our patients.
I'm finding myself already so excited about this panel, and we're only a little bit of the way in. So thanks, you guys. I love hearing, and I've heard you talk about that 3-pronged definition of provider status, which I hope for the folks that are attending, that really clears things up for me and helps me look at thinking about, statute, payment, and scope of practice. And I've heard folks say top of education instead of top of license to address the fact that pharmacists are trained to provide care at a very high level, even if the state scope doesn't necessarily reflect that. Thank you, Bob, for talking about privileging and credentialing in the health system. I think we're going to be learning from what some of our health systems, especially our innovative health systems, have done in that area as we expand provider status into our outpatient areas too. What does that look like, and how can we move some of those best practices out? And Stu, I have one follow-up question for you. As you talked about all of the exciting things happening in Ohio, I'm thinking that our panelists are both kind of local to the state as well as across the country, and either way looking at what we're doing in Ohio. And so these initial rollouts have happened with these 4 plans, and what's next? So what's on the horizon in the next 6 to 12 months when we talk about the provider status evolution in Ohio?
Yeah, so I think there's a few different ways that I think this is going to go. The first is we've been spending a lot of time with the Department of Medicaid, and we've been putting a lot of our effort with the Department of Medicaid, and there's a lot of reason for that. One is there's been a lot of public pressure with the articles that have been in the Columbus Dispatch and everything that was going on with PBMs, and the fact that the PBMs were found to be essentially overcharging Medicaid. So there's kind of reasons to go to Medicaid first. The other thing that's happening literally right now is all of the Medicaid managed care plans in the state are currently under reprocurement. So they are reapplying technically to continue to be a Medicaid managed care plan, as well as outside entities trying to get into the state. Because of that, it made a lot of sense to go to Medicaid first and to go to these managed care plans, because they wanted to show, hey, pharmacy, like, we don't want to screw pharmacy over. We want to help pharmacists. We know pharmacists can help. So we started these plans and we started having these conversations with them. And I can tell you early on, being on some of these calls and meeting with some of these executives, a lot of those early conversations, I mean, let's be honest, they were doing it just to get on pharmacy's good side. But they quickly, and I mean very quickly, realized that, wait a second, there's something here we've never tapped into. This truly is a healthcare professional. This is somebody that really can open up access. And we went with one of the plans to one of the sites, and the folks from OPA that are with me were kind of thinking, oh my goodness, this is a typical pharmacy. It's got the wood paneling on the wall, and like, we've got these executives that flew in from San Francisco. What are they going to think? And they absolutely loved it. And the reason they loved it is because they knew that those pharmacists knew every single person that walked in the door, every single one of them. They knew their name before they even handed them the prescription. And they're like, we have nobody else across our continuum that can do that. So they started to recognize, like, we do need to incentivize these folks, and they really can help. So where we are going from there, the Department of Medicaid, we're waiting for them to release rules, and they're going to release rules for the final, essentially rules around what payment will be for pharmacist services. And they released a draft of those rules back in late June, early July, and those were only available for about a week and a half. Since that time, those came back down, and we've been meeting with the Department of Medicaid, and I'm actually surprised they're not out yet. Those rules should be out soon. And I can tell you that our lobbying efforts worked. One of the biggest things we were concerned about in those initial draft rules is that the department was originally saying that there needed to be a collaborative practice agreement in place in order to get payment for services. So we pushed back on that pretty hard. And that's because we recognize, and as Bob mentioned, I work under collaborative practice. So I recognize the efficiency of what that can do, but we really think that that's going to be limiting to make this, to really point out what we're trying to do, which is gain access to our patients. So if you're in a community pharmacy, you're going to have collaborative practice with potentially 10, 12 different offices. You're going to have to think about what exactly can I do for this physician versus that physician. And we don't want our pharmacists thinking of that. And the other thing is, you think about institutions like Ohio State, you may have an independent pharmacy in one of the suburbs, and they may want to partner with an Ohio State clinic that's right across the street. But because of the entity of being a large organization, that physician's practice may be like, oh, well, you can't do that because we've already got our own credentialing program and we've already got our own pharmacist. So again, limiting it. So I'm happy to report that, at least from what we're hearing, the Department of Medicaid has listened to us, and they've kind of walked that back a little bit, and they're no longer going to require collaborative practice agreements to be in play. Now, there's going to be some other guardrails. It's not going to be just like completely open this up and pharmacists can bill for whatever to get paid. So there's going to be some time to kind of figure out what those guardrails are. But when those rules come out, I truly would anticipate in the next week, please watch for those and look for guidance from the pharmacy organizations as far as the things that we are seeing, and please provide feedback to the Department of Medicaid. So that's kind of on the Medicaid front. But we're not only talking to Medicaid. So we've been in contact with the Bureau of Workers' Comp, so BWC, to talk about some initiatives there. We've talked to some various commercial payers to see if they have some interest in paying for services for their patients on the commercial side and private insurance. And we've also talked to some folks in the Medicare Advantage space, which is really, really exciting to think that we can't do this with Part B and straight up Medicare, but they can actually have some flexibility within Medicare Advantage plans to potentially do this. So really what we are trying to do is come at this from all angles, because again, what we want is we want to move the profession forward. We want pharmacists to be practicing where they should be practicing. And when a patient comes into a store, when they come into a clinic, when they come into the hospital, I don't want that pharmacist to have to think about what insurance do they have, what doctor am I with. I want that pharmacist to be taking care of that patient. That's what we do, and that's what we do best. So let's get to the point that there's enough payment that's out there that that's what we can focus on.
And I would agree, Stu, that there's way too many barriers and walls between us, between the community and the hospital. And I totally agree that it should be seamless. And I think the privileges or what folks do should be broadly defined so that it really allows us to really practice pharmacy versus just implementing protocols with our patients. We all know that patients respond differently to medications. And so we need to have some flexibility to really practice pharmacy, just like physicians practice medicine as well.
And I'm super excited to hear that they may be removing the collaborative practice agreement requirement. I think as a profession, we need to separate enabling practice enablers like collaborative practice agreements, which can be very, very helpful in taking away the need to call and get a recommendation to change therapy, but they really shouldn't be tied to payment. So that's absolutely awesome news. Makes my day.
Excellent. Thanks
I
so
would,
much.
and
Oh, sorry, go
Jen,
ahead, Ann. Yeah.
I was just going to say, I would add one other thing, just in looking across the landscape, Washington State has a little bit different approach in that their legislation through their insurance code is with commercial payers. And so as opposed to Ohio, which is rolling out primarily in the Medicaid MCO realm, we're watching that very carefully as well. And I think as a profession, we need to think very carefully. And Bob, I know you've gone through some of this in the health system, but it's not, okay, check the box, you're going to get paid. It's now there's all kinds of layers of things that we need to put into place. Like as a pharmacist, you need to become part of that payer's credentialed network. So you have to go through their credentialing process. And depending on whether you're in an institution who can do it kind of as a group, or whether you need to do it individually, it can take like 6 to 8 months. Was the Washington State experience to basically get enrolled as a provider with a payer. We call that the credentialing process. And then the documentation, you have to have the documentation systems in place, and billing, how do you go about billing? So there's a lot of things I think that we always talk about whether pharmacy is the, do we get the payment and then provide the service, or do we provide the service in the hopes that payment will come? And I think we're at a point where we're starting to see this unfold. So now we have to get ready. And I know pharmacists are busy. I know there is high stress. I can't agree with Bob's comments more. But really as a profession, we need to understand what needs to happen and get ready so that it's not years to get things implemented.
Yeah, and it seems like there's lots of bureaucracy in organizations around pharmacist billing. Mm-hmm. And I know that at Ohio State, there's just so many machinations of things we had to go through to really even get to where we're at with billing now, because folks are afraid of fraud, right? They're afraid of something being interpreted negatively or fraudulently. And as a state organization, obviously, we have a responsibility to make sure that doesn't happen. So that's, I think, part of the issue. So I think part of the strategy on pharmacy leaders is to sit down and have clear and transparent conversations with people that are responsible for those systems to make sure they know what you are proposing to do, what are the laws around it, what are the boundaries, and make sure that it's really clear up front what you want to do to really prevent explaining yourself continuously to people as you try to navigate through the billing process. So I would just recommend people out there really make sure they're clear on what they're going to do, how they want to do it, and how does it really sync with their organization's billing processes and procedures, or companies' billing processes.
Yeah, there's a lot of new stuff coming. And so I think it's an exciting time, but also very much a time of change. So along those lines, I'm going to throw another question out here around some of the rapid change that's happened. The pandemic has impacted practice change, care delivery, specifically with regard to immunizations and some executive orders that have come forth. So I'd like to hear a little bit from our panelists about some of these rapid big changes and how that's impacting pharmacists and healthcare and practitioners across the country. And maybe we'll start with you on this one.
Sure. And I would actually, throughout this, I think it would be great to hear from the audience as to, are they implementing some of these changes, and what barriers or concerns they have. So HHS came out recently actually with 2 different executive orders. The first basically clarified that pharmacists could order and administer COVID-19 vaccines, and that order supersedes any state requirements for pharmacists to have a collaborative practice agreement. And I don't know if I should have looked what Ohio's authority is coming in. But basically that was a tremendous step, because we want to position pharmacists using a service that has been wildly successful for us and actually has a pretty good business model for it. So that was very exciting. And then they came out with 3. And the next one they came out with basically authorized pharmacists to immunize children 3 years and older. And there are, I think, 22 states that already allow this. But the thought was, with access issues during the pandemic, and pharmacists, to Stu's point, because I can't tell you how important we need to play up the access piece as it relates to pharmacists. Just, it seems like everywhere that's what resonates. But anyway, there were concerns about children not getting vaccinated, and so HHS basically authorized pharmacists to immunize children 3 and above. Also pharmacy interns working under the supervision of pharmacists. And they do have some requirements. You have to have completed a 20-hour continuing education program, and you need to, every year when you renew your license, you have to have 2 hours of immunization-based CE. But interestingly, it's not specific to say it has to be in pediatrics. So that's kind of, I guess, an oversight. I don't know. So that, I think we've heard mixed emotions, honestly, from pharmacists about comfort level, and it does require some continuous professional development in some cases if you haven't been trained in appropriate needle sizes and appropriate injection technique, but we really viewed that positively. I think the most interesting executive order came out last week, I think it was, where CMS or HHS came out and said that pharmacy technicians and student interns can administer COVID vaccine under the supervision of a pharmacist. And so, I think as we think about all the changes in healthcare that are happening, how we utilize our support staff is incredibly important. There are several states that already authorize technicians to to administer vaccines under the supervision of a pharmacist, but this is wide scale authority. There are some training requirements. The technician has to be a certified pharmacy technician, but just, I think what I've been amazed about across the board, not just in pharmacy, is the relaxation of just so many different requirements to try to maximize healthcare delivery. And so how as a profession do we capitalize on that as well? So those are the primary immunization authorities that we're seeing. There's a lot of confusion when HHS issues an executive order, because then at the state level, if it's not something that's allowed, different states have approached it differently. Some of them feel like they need to issue their own executive orders so that it's aligned all the way across. Others have issued conflicting advice. So it's moving fast and furious, and there's just a lot of work underway to try to clarify things as we move forward.
So how have those orders been received or influenced what's been happening at the medical center, Bob, or at the, from an OPA perspective, Stu?
So we have not been doing the 3 to 7 age group for a variety of reasons, just in terms of just logistics and so on. But what this has done for us is we have dramatically expanded our flu clinics across the entire health system. And we can use different folks to do that, obviously student interns, pharmacists. And we've got now 30 clinics or so scheduled and, vaccinating, 1,200, 1,500 patients. So it's just something that we've really focused on in the last few years. And it's really a focus this year because obviously flu is so important. I think just the attitude around pharmacists and the acceptance that a pharmacist can give you a vaccine, and that sort of public acknowledgement almost establishes our credibility in a way. Mm-hmm. And I think it's very helpful for us, obviously to have that. So we've really sort of really ramped up the flu vaccine, really are going to be very, very laser focused on the COVID vaccine. We have a group together doing that. And hopefully we'll be sort of hand in hand with everybody else as a sort of provider on the same page, obviously, taking care of these patients. So yeah, I think that's been a big positive benefit of all the press.
Yeah, and I'll say I have a couple of things on immunizations. One is from the clinic side of things. Our pharmacists at General Internal Medicine, where I work, and at Family Medicine, we actually operated drive-through flu clinics as pharmacists, and we did have a nurse practitioner staff that with us for the children that were there. We can go down to 7, but just for ease, we just had a nurse practitioner there. But we had 4 different stations of pharmacists essentially delivering immunizations, and we used the same workflow that OSU has been using for COVID testing. So the drive-through COVID testing takes place during the day, and then we had our pharmacists going over, and I don't know how many of those we did, but I know that we immunized over 1,000 of our patients, and patients absolutely loved it across that. So it definitely opened that up for us, and I would imagine we kind of joked, we're like, now that they know we can do this, I bet when COVID hits, they're going to want us to do this again.
Yeah, that's exactly right.
So that's kind of on that side of it. But I will say from the OPA thing, just because of the relationships that we have all of a sudden with the payers, we've had some conversations around immunizations, and the MCOs basically saying, we hear from the state every single year, you guys need to get your flu vaccine rates up in the Medicaid space. And they were saying year after year, they're always telling us to go to the PCPs, to the physicians. And he said, this is the CMO of the Ohio plan. He's like, we've always gone to the physicians and we've never made a dent. He's like, I'm sitting there thinking in this meeting that I've heard for the 3rd straight year, why don't I go to these pharmacy guys? They've got access. Why don't we come up with some type of program where we're actually offering pharmacists an additional incentive? So we're kind of coming up with that and playing with it. I don't know that we're going to get anything into place this season since it's already November, but there's some pretty cool and pretty innovative things that the plans are thinking, hey, maybe we can pay pharmacists or incentivize them that if they get a certain percentage of this particular patient panel, they get a bonus payment for it. And I'm trying to take that even a step further and say, let's actually get a pharmacy service on there. So it's not just an immunization. What if we did an entire screening for these folks that aren't coming to the physician, almost like an annual wellness visit in the Medicaid space, to actually start to screen for some of these diseases. And they were kind of like, whoa, we hadn't even thought of that before. I love that idea. So we'll see if any of that takes place. But I do think that a lot of this provider status stuff has just opened up new relationships and opened up eyes to really get people to think about what is the value that we can bring. And we really have this untapped resource, maybe not completely untapped, but for the most part, an untapped resource here with these pharmacists.
And first of all, I love this conversation. And second of all, I think it's important, and I'm guessing everybody who's on this webinar knows it, but these authorities are only in place while there is a public health emergency. And the government renews the status of public health emergency every 90 days. So I think right now it's through the end of the year. But, you know, this is our golden opportunity to show that we can come to the table in so many different ways. And, you know, everyone across the board, not just pharmacy, is talking about how do we extend all of these authorities that in many cases have improved, you know, what different providers can do, including pharmacists. I will say it's been interesting kind of in the political frame when HHS came out with the pediatric vaccination going 3 and above. The American Academy of Pediatrics was very vocal, really across the country. And the interesting thing is there has been enough pushback, it seems like anyway, from organizations outside of pharmacy and pharmacy organizations working with that group as well, that we're just not hearing the frustrations and concerns like we did in the beginning. So I guess we'll see, but it's just interesting how sometimes the turf battles play up when things like this happen.
And thank you for bringing that up. And there was a question that actually came in the Q&A, and I know I said we'd wait till the end, but this just fits right here with what we're talking about. So I want to ask it is, you know, asking, do you believe, and so this is kind of a question really for the panelists, that some of these HHS orders will last beyond the pandemic? You know, I wonder in Ohio, but also looking across the country, and what is it beyond engaging in these allowances that have been put forth to showcase that this is something pharmacists can do and that may help? What can be done, and what do we think is the likelihood that they may continue after the state of emergency?
I think it's up to us, actually. I think we need to be enthusiastic. I think we need to accept these expanded responsibilities enthusiastically. We need to be competent at doing these things. We need to meet the needs of our patients. If we meet the needs of the patients will speak, and the patients will talk to representatives, they'll talk to council people, wherever. And I just think it's up to us to really enthusiastically and positively embrace and conduct these expanded responsibilities. I think that's how we win it. And obviously folks like Stu and Ann who can use their skills in advocacy and talk to the people in charge and really convince them that, hey, this expanded role really helped our patients. It met an unmet need.
Yeah. And I totally agree with Bob. I think just a couple of additional things to think about. You know, I think there'll be monitoring for safety. So it's been great so far. We're not hearing of any major safety problems with any of the waivers. And this includes even a lot of the ones that are occurring at the dispensing realm, where the pharmacist can extend refills and do some therapeutic substitution and so forth. So I think the safety component will be there. We're starting to talk a lot about what kind of data should we be collecting to push that there were positive outcomes from these decisions and to provide more evidence for keeping the authorities. I think a lot of them will continue, maybe not quite in the same form that they are right now, especially telehealth And I know that's on our topic, so I'll wait to talk about it till then. But I do think a lot of them will change. And we have a weekly COVID webinar, and we had the executive director of NABP, the National Association of Boards of Pharmacy, on a couple weeks ago. And he indicated that one of the things that they've learned is that they have a lot of administrative processes that are burdensome in state boards. And they're going to be looking seriously, as they've seen all of these activities roll out in COVID, to what they can even extend from a state board perspective. So I thought that was really encouraging as well. We're the most over-regulated profession across the board. So I think easing up, and as Stu and I think Bob have both said, allowing pharmacists to take care of patients is really what we're trying to accomplish.
Yeah,
Excellent.
absolutely.
Okay, so I'm going to move us on to our next topic of conversation. And you alluded to it, and nicely segue here for us. So what are you guys seeing with regard to how the pandemic has influenced changes in pharmacist provided delivery in the telehealth area? I know there have been some significant changes there. So interested in what you've experienced, and you kind of give us a little teaser that you'll talk about what we think about what that might look like after the state of emergency. Bob, do you want to start us off on this one?
Yeah, sure. So obviously March 13th, everything shut down in Ohio, and we were meeting as a group here and talking about how we were going to manage things, and surgery stopped and everything kind of came to a halt, and all these appointments stopped as well. So we had been trying to implement a telehealth program at Ohio State for 5 years, and we did it in like 3 weeks. So what does that tell you about decision making and crises, right? So we all had sort of a purpose-driven lifestyle here at Ohio State. The purpose was to take care of COVID patients whatever way we could to keep everybody safe. And so we developed a full-blown telehealth program within 3 weeks. And I kid you not. And in fact, we always kind of joke about it. There's so much bureaucracy here at Ohio State at times that we just need to kind of take these layers away after COVID goes away. So we were doing about 60% of our visits by telehealth. There's lots of ways it needs to be set up. There's various systems that need to be changed, different computer systems. It all has to be HIPAA protected. There's a lot of bells and whistles and things. Obviously, Stu does this as well. We've gone back to seeing more patients in person, but we're still at about 20 to 30% of our patients are seen by telehealth. And it's actually something that the providers find very helpful. The patients like it because they feel safe at times. And really it hasn't impacted their ability to do their job. They're able to assess the patient. They're able to give them advice appropriately. You can hear, you can see people. So I think for the future, I think it's going to be a mix. I think we're going to see a lot of chronic patients by telehealth. So I would say an ambulatory pharmacist will see, community pharmacists will see maybe 40% of their patients by telehealth and maybe the other 60 in person. It's kind of where I think it's going to end up, but I'm just curious as to what Stu and Ann think about that.
You want to go ahead, Ann?
Go ahead, and then I'll close.
You'll close? Okay. Well, yeah, again, from a clinic standpoint, again, I work in general internal medicine, and it definitely had an uptick really quick. We've been really fortunate that we work with an early adapter, Dr. Tile, who's he's the former director of the division, and he's our physician partner. Actually, he just won he's getting ready to win the Friend of Pharmacy Award. So you should listen to him talk whenever the pharmacy virtual gala is coming. But he's such an early adapter. He was doing a lot of these telehealth things really over the last 4 to 5 years. And he actually is one of the people that helped train and teach other people across the whole medical center for how to do that. And so some of those things were already in place. Our pharmacy team has been continuing to work remotely. Some of us are going to the office, but we're doing both. So we are doing phone visits and video, mostly phone, but we do a little bit of both. And it's actually worked out to be not much of a problem at all. Patients like it. They don't have to come in. A lot of the stuff that I'm doing as a pharmacist doesn't really require physical assessment. So I can talk to them over the phone. I can figure out what their blood pressure numbers are, their blood glucose numbers are, and make adjustments that way. Then I can call them in another 2 to 3 weeks. So it's really been nice as far as that goes. Again, if I put my other hat on and I switch back to what's going on with OPA, again, I've been very clear, and I think it's because of where I've practiced, that whenever we talk about these codes, and it's always like, what codes do you guys want? I'm like, well, I want the same codes everybody wants. But that doesn't ever work. So we have to kind of go down from there. But I've been very clear that this should include telehealth codes for pharmacists. And I think that's important across practice setting. So even if you're in an independent community pharmacy and we talk about access, and that's what we can do, and we certainly can, and that patient may be coming back to us every 30 days, but we may want to touch base with them in 7 days to see that they actually finish that antibiotic, and they don't need to come in the store for that. Or we may need to talk to them a couple weeks out and see, hey, how's your blood pressure doing now that we made that adjustment? Why do we need to wait 30 days for that? Again, we can be an access point with telemedicine. And I'll tell you one of the other things we talked about with the plans, which is super exciting. Again, when you start to see their wheels turning, it's pretty exciting stuff. And they're like, well, wait a second. If you guys are doing all this delivery, like we've got all these needs as social determinants of health. And we're like, well, yeah, why don't we start to have our delivery person take an iPad with them and actually do a video visit with some of these homebound, extremely high-risk patients that know the pharmacist, so they're high risk, but they have that relationship there, actually allow them to use some type of iPad that the delivery person has, and you can get across and have this basically a video visit with this person. A lot of times, even the pharmacist doesn't communicate with because they have to have a caregiver or someone else pick up the meds. I can tell you, I used to do home visits for a brief period of time, and it's every single pharmacy student, if there's some way to do it, should do a home visit. It's the most eye-opening thing you'll ever see. I will never forget, I'm literally at this lady's house who was in the hospital for about the 6th time in the last 9 months for a COPD exacerbation. I'm going over her meds with her, and I'm pulling inhalers out of the couch. And I'm like, what about this one? What do you do with this one? What about this one? What do you do with this one? And then, I mean, there's like, you know, we have automatic refills, and I had 9 Spiriva inhalers stacked up. And I'm like, do you use any of these? She's like, no, but every time I go to the pharmacy, they give me a new one. So I mean, going into the home or being able to do that with telemedicine as a pharmacist is going to be critical to allow us to prevent med errors and everything else. So I'll stop. I'm getting all fired up, and I'll turn it over to Ann, who will take us home.
I don't know if I'll take you home or not, but first of all, I totally agree with Bob and Stu. I mean, telehealth is probably the most revolutionary aspect that has come out of the pandemic for sure. And for those of you who aren't aware of the telehealth requirements, and I think Bob and Stu both mentioned HIPAA, the patient had to be rural and in a specific location, and the provider had to be using very specific technology that was HIPAA compliant. And basically everything has gone out the window. It's almost like email, we're hearing text is incredibly effective for some types of communication with patients. Audio visual is really the gold standard. CMS has released a whole host of codes that go with specific types of delivery mechanisms, asynchronous, but also for live telehealth visits. And so I think what we'll see is kind of after the pandemic is over, everybody's going to step back and say, okay, what works and what doesn't? Because there is a lot that's being paid for now that didn't used to be paid for. You know, email communications were not paid for, but now they're being paid for. Just a telephone sometimes counts as an office visit, but they also have telephonic codes now. And so I just think from a healthcare resources perspective, it will probably stay. What we have will probably stay, but what's permitted by payers may vary to some degree depending on patient complexity, or I don't know how it'll work, but it's amazing for patients. From a personal perspective, I'm a caregiver as well, and we have on average 3 telehealth visits a week. And so we've done them every which way you can imagine, but it is incredibly helpful. And I think there's a really important role for pharmacists in telehealth delivery. And just I would end on two different authorities that CMS clarified or provided. One is, and it's related to payment. So in order for physicians to bill for pharmacist services in Medicare, for most office visits, the pharmacist has to be co-located, like in the general office suite or in the outpatient hospital clinic. I believe it's the building, right, Bob? Or basically, it's not conducive to pharmacists who are not located with the physician. But during COVID, CMS has made has given the waiver that for the physician needing to be immediately available by audio-visual delivery. So that opens up a lot of possibilities for collaboration with pharmacists who may not be co-located. And we'll see if that supervision requirement stands. The last thing that CMS clarified, they've always said that they would not recognize or cover medication management services in Medicare Part B because they pay for them in Medicare Part D. And during the pandemic, they came out with a big clarification around pharmacists as auxiliary providers. And the net new thing was that medication management services could be provided in Medicare Part B as long as they're not at the same time provided in D. So it's a win, but it's kind of a confusing win because I have no idea how they'll ever know. But I think it's progress and it recognizes the value of pharmacists. So that's all I have to say.
That's fabulous, Anne. And to clarify, when you were talking about that auto-visual connectivity, that's for Incident 2 billing, is that right?
Correct. Yeah,
Okay.
it's for the supervision component in order to be part of an Incident 2 physician services arrangement.
Absolutely. And that is exciting because that in the building limitation has definitely been one for Incident 2.
Yeah.
Okay. Oh, go ahead.
I know we're at time. I was thinking it would be fun to talk about COVID testing and some of the payment implications there, but we can do that at another time.
That is definitely another very good conversation. I want to get to at least one question from the audience because we do have a number that have come in. And so I'll let everyone know, thank you for putting some questions in the Q&A. I'll ask one question just to kind of wrap us up. And then the other questions, what we'll do is get answers from the panelists and we'll make sure to send those out. So I see a question here about how would you encourage future pharmacy leaders to motivate employees who may not be as excited about some of these big changes that are happening? This is a lot of change really quickly. So what is some advice you have?
I would think, me as a leader, I would number one, find out what their issues are. I would find out why are they afraid? Are they afraid of something? Is there something that's bothering them about the change in responsibilities? But then leading by example. I give flu shots. I'm very enthusiastic about it. I'm very connected to patient care within the medical center. So really leading by example and really trying to fix whatever issue is bothering them around some of these changes in what pharmacists do.
Do you want?
Yeah, I would just say, I would completely agree with Bob. Lead by example. One thing that we found in these implementation projects is it's the pharmacist nature. We're pretty apprehensive people, or sometimes risk averse people. That's why we're so good at what we do. But on the flip side of that, now's kind of the time to be like, we got to go out there and we got to kind of go out on the branch a little bit. And these pharmacists have adapted very, very quickly. There's so much out there that I mean, I don't want to like short sell it at all, because it's not, but there's so much, for lack of a better word, low hanging fruit. There's so many things that are not being done out there that pharmacists can help with, that we just need to go out there and start doing it. And the pharmacists, they were very nervous, extremely nervous. And after they saw the first patient, they're like, oh, this is what I went to school for. I'm so excited to finally be able to get to do this. My patient loved it. I called the doctor. The doctor didn't hang up on me because I was actually talking to them about their patient. So we've actually got pretty good early adoption from them. If there are people that don't want to do it, I think you have to lead by example. I think a little bit of tough love, to some extent, it's kind of like, this is where the profession's going. If you still think you're going to get paid on dispensing fees, I don't know what you've been looking at the next few years and where you think the future of pharmacy is going, because it's just not going to be there. So to some extent, they're going to have to adapt and learn a little bit. Now we need to take time. We need to make sure they've got training. We need to make sure we train them up. We need to make sure our students are ready to go. But this is the future. This is the profession that we've wanted. And now's the time to actually make it happen.
Okay, that's a perfect place to stop, I think, if that's all right, because we are at 8:01 and I know folks need to go. And do you have a few words you want to say?
I would just say, I totally agree with Bob and Stu. I think it's communication and confidence. Also looking at the practice site to make sure that it's conducive to pharmacists providing the service. So I'll end with that.
Yes, we have so much more that we could talk about. Thank you, thank you, thank you. So thank you to everyone who attended this evening.
Yeah.
Special thank you to our esteemed panelists. I'll kind of wrap up. I want to bring my little metaphor back. Unlike the tortoise and the hare, I'm not sure we know where the finish line is, but I appreciate all the contributions that you are all making to the race as we move forward as a profession on this journey. So thanks, everyone. Take care, and everyone be well.
Thank you.
Thank you.
Thanks so much.
Thank you, everybody. Goodbye.
Bye-bye. Thanks, Henry.